going to share a little bit of information that I think will be pertinent to the discussion. So there are about 38,000 suicides each year in the United States. That's about a suicide every 13.7 minutes. It is the 10th leading cause of death in the United States. There are a lot of things that affect it, some of which you heard here among the young people, but socioeconomic status, employment, occupation, sexual orientation, gender identity, all of these things play significant roles. In the age group that the film addressed, that is 15 to 24 years of age, there are about 4,500 suicides per year. And as they pointed out, it's the third most important cause of death. That's about 12 per day, or about 1 every 2 hours. So about every 2 hours, a young person between the age of 15 and 24 commits suicide. Now, if you look at the age groups, this is among the lowest age group. Actually, the groups that are at highest risk are older people for a lot of reasons. But nevertheless, this is a vulnerable age group for all the reasons that you just saw. Suicide rates, you may not realize, are 4 times an important point to remember. In terms of our community, there are probably a little bit of good news in that among Hispanics, the suicide rate is far lower than other ethnic groups, particularly among Caucasians. But we're in the West, and suicide rates are higher in the West than they are in the East. An issue that's under debate today, literally, is that of firearms, the availability of firearms. We heard about a 6-year-old child being shot by a 4-year-old today on the news, and that's not unusual. One of these things happens every day. Well, it turns out that about half the suicides are from firearms. What you may not realize that almost 500,000 people a year visit a hospital for injuries due to self-harm, effort at suicide. And that ends up with 650,000 hospital visits per year. It costs about $3 billion annually for Medicare, and another for medical care, I should say, and a $5 billion for indirect costs such as lost wages and productivity from people who commit suicide, but who do themselves harm in perhaps effort to commit suicide. This is, in fact, a major issue in our population. And just today, as we hear almost every day, a 17-year-old in Canada, 17-year-old girl hung herself. She was taken off of life support today. She hung herself because she was allegedly raped by a group of 4 boys when she was 15. The pictures were put on the internet. She became depressed and became suicidal and hung herself. That's just a news report today. So we hear these, and our colleagues on the panel, I'm sure, are faced with many of these issues every single day. So keep those things in mind. It's now my pleasure to introduce the panel in more depth and to get started with our discussion. Becky Tresnicki and Becky, if you want to come on up. Becky is currently the Director of Behavioral Health Services at Valley Baptist Health System. She has a master's degree in social work from Our Lady of the Lake University in San Antonio. She's a certified anger resolution therapist and is proficient in laws pertaining to mental health and mental retardation. She has 15 years of clinical experience in clinical executive management, and she was an adjunct professor at the University of Texas, Brownsville, and we hope you'll continue to work with the university. She was the director of the Clinical Authority Services at Tropical Texas Behavioral Health and served as assistant clinical director of the Rio Grande State Center. Ms. Tresnicki organized and facilitated the opening of the behavioral health services for the Valley Baptist inpatient unit. And I can add that we are in the process of interviewing potential directors of a new residency in psychiatry that we hope will be centered around Valley Baptist. So, Ms. Tresnicki, thank you very much for being on the panel with us. The second panelist, Dr. Francisco Torres. Dr. Torres is a board-certified psychiatrist practicing in Brownsville. Dr. Torres did his medical studies at Harvard Medical School and his clinical work at Boston VA Healthcare System. He was also at the Weill Medical College of Cornell and Lincoln Hospital for clinical training. Dr. Torres was the clinical assistant professor at the University of Texas Health Science Center, I believe in San Antonio. Is that right? Yes. Yeah. Okay. He has been appointed the president of the JNC Behavioral Services, and I don't know what JNC is.
It's the name of my clinic.
Okay. And he was the interim director at the Valley Baptist Medical Center outpatient, and he is licensed by the Texas Medical Board. He has received the Faculty Horizon Award from the University of Texas Health Science Center in San Antonio, and he also received special awards for outstanding performance from the Brockton VA Medical Center, Harvard South Shore Psychiatry Training Program. So, Dr. Torres, we're pleased to have you in the Valley, and thank you for being on the panel. The next panelist, Dr. Daniel Gutierrez. Dr. Gutierrez is currently Chief Medical Officer at Tropical Texas Behavioral Health and is Adjunct Professor of Psychiatry at the Health Science Center in San Antonio. And I believe Dr. Gutierrez has brought one of his students along, which we're delighted that she came. And Dr. Gutierrez graduated from Universidad de Montemorelos in Mexico. He completed his residency in psychiatry at UTMB in Galveston and a fellowship in child adolescent psychiatry at Timberlawn Psychiatric Hospital in Dallas. Now, finding child and adolescent psychiatrists is not easy. And so we are particularly grateful that Dr. Gutierrez joined us tonight and adds his at least 20 or more years of experience working with adolescent and children to our discussion. He's board certified in adult and child and adult psychiatry. He's worked in the last 20 years, as I mentioned, in South Texas in private practice as medical director of several inpatient units, in community mental health and consultation with courts, schools, and foster care programs. So Dr. Gutierrez really does get into the sort of the underbelly of health and public health, because these are all difficult areas, and we truly appreciate your service. And last but certainly not least, Jorge Munoz, who's a student development specialist. He is currently a student development specialist with UTB. In the student health services. He holds a bachelor's degree in psychology from UTB. He's in his final semester for his Master's of Science in Social Work at UT Pan Am. Soon to be UT, we're not sure what, but now that the two universities are coming together. Mr. Munoz has been a suicide prevention instructor for the past 2 years and has co-led numerous trainings in suicide prevention with Dr. Eugenia Couret, who couldn't be here with us tonight, at the UTB campus. He's also worked with the Brownsville Police Department, the local school counselors, and nurses. Mr. Munoz has been involved in the development and implementation of a training curriculum on bullying and its effect on children, so a most appropriate experience to share with us tonight. He's been an intern at UTB Student Health Services, a mental health unit for the last year. So we are privileged to have a very distinguished and experienced group of people on our panel, and we thank you all for sharing with us. And I have to make a disclaimer. I am not a mental health specialist. I am here to just to try to moderate and ask some questions, but we appreciate the expertise of our panel. So we're going to take this in sort of sections. We're going to start with depression, and we'll ask our panel a number of questions let them discuss the issue of depression, and then we'll open that up to a few questions from that you may have. Then we'll move to the next section, which is bullying. So we're going to try to cover a number of the issues that you saw in the film, but get the input of our panelists. So, Dr. I'm going to start with Dr. Torres, if that's okay. Dr. Torres, what if you are a family member or a friend, what would you look for, and how might you recognize signs of depression, particularly in adolescent or in anyone, but particularly in adolescent?
Well, I think the family members, they have to be aware of any major changes on behaviors. Adolescents, when they're feeling depressed, they're very quick on starting to change patterns of behavior, maybe giving up on activities that they like to do or to enjoy, maybe hobbies. Sleeping patterns also change a lot, not being able to sleep, and I think this is particularly very sensitive. It's something that we look for when we evaluate young patients. Most of the time they complain about insomnias. Given the age of these patients, they go through different changes in their hormones and different patterns, and one of the things that we see commonly on them is having difficulty sleeping. Other things that we look for is maybe statements where they express that they have been feeling sad or not feeling that they're having a good fit with their social group in school, or when they start to mention repeatedly that things are not going well in school. It could be either their grades or the fact that they're having difficulties with some of their peers, like as we saw in the film. Bully is being bullied in school. It's one theme and topic that we are seeing more frequently in our consult in the psychiatric clinics. We also have to look for major changes on appetite, energy level. Sometimes they don't feel that they want to do anything. Their level of motivation starts to go down, sense of hopelessness, helplessness. And for most of the part from the cases that I have seen in my practice, the young people, they make the statements and they try to communicate that something is not going well, and they have maybe a difficult time trying to communicate that they need some help, but through these type of statements, they're implicitly asking for some degree of help from the people around them.
Okay, thank you very much. A second question that's very much related to this, and I'm going to ask this to Dr. Gutierrez, are how would people recognize some of the key warning signs of suicide in these young people?
Well, I think one of the, please let me know if you're hearing me. I think one of the things about suicide is that people sometimes keep it to themselves. As we were talking about, a lot of the people, there's some myths about it that people usually will leave notes, and the majority of kids don't leave notes. So most of the time, the parents don't know, and a lot of times, there's some blame sometimes towards the parents that why is it that a parent picked this up? But a lot of the times there's a communication gap. If, as the Dr. Torres was saying, that there's the adolescent sometimes becomes more withdrawn and apathetic and less communicative, and sometimes parents just feel like, they're just being adolescents. They're just wanting to be in the room and wanting to be on the computer or on the phone, and we're just letting them get through the stage. But I think parents really sometimes don't know. I sit a lot of times in front, and as I interview children or adolescents, and I ask them about symptoms or signs that they have, and I see sometimes surprise on the parents sitting beside them saying, really, you've been experiencing that, you look the same to me, I haven't really noticed any changes. And it's not uncommon for children and adolescents to say, yes, I've been feeling this way for a long time, and I usually keep this to myself. So I think, you really have to ask these questions very directly. Do you have problems with sleeping, appetite? Do you withdraw? Have you noticed changes in your behaviors, in your interests? This feelings of hopelessness and helplessness is very concerning, because sometimes when people get to that point, they just can't see beyond that. And for the people around them, they say, well, you have everything. I recently had a parent tell her daughter this week, you should have seen me when I was your age. I had to do this, and this, and this. I didn't have the things you'd have. I didn't have a cell phone. And so the parents are kind of upset a little bit that how is it that you can feel this, so you have so much, and that maybe I didn't have these things, and you would want to, and you would feel so depressed, and you wouldn't want to live. I think there's, how would you recognize the issue of suicidality? Is you have to look at mental illness, and especially depression, because most of the kids that become suicidal have some form of depression, and as this depression becomes more severe, there's more risks of this. But there's other concerns, isolation from their friends, isolation from activities. They stop playing sports. They might start using drugs to self-medicate. They don't sleep at night. They stop performing poorly, performing in school. So you start looking at all these things, and if you have depression, and one of the things that I think is very important about suicide is if there's a previous attempt. The biggest predictor of a future suicide is if someone has tried to hurt themselves in the past. So you want to ask them very directly, do you have suicidal thoughts? Do you have suicidal plans? And this is not going to make the situation worse. It really helps them being able to express that they have these thoughts, and you want to be able to intervene. So.
Okay, thank you very much. I'm going to ask this question to Becky Tresnicki. That is, how, and I think folks here in the audience might be very interested to know, so how do you address a friend or a family, somebody in the who's either a friend or a family member who appears to have some of these symptoms of depression? How do you address them, and what do you do to approach them?
Well, I agree with everything that Dr. Torres and Dr. Gutierrez have said in looking for the signs and the symptoms. I think if you are a family member or a friend of someone and you see some of these things going on, the first thing is to, if you have a friend, you know their patterns, you know their behaviors. So if you start to see something different, please be aware of that. Be willing to talk to them. The lady on the movie said, she said, I may not know the answer, but we can find out what to do. Be candid, be open, and be available for them. Don't be afraid to ask, do you feel like you are going to kill yourself? Do you have a plan? Do you have pills? Do you have a gun? A lot of times as a family member or a friend, we are afraid to ask those pointed questions. We think that they're going to go ahead and throw someone over the edge, so to speak. But it's very important to be able to ask those questions so that you can be their resource, be their support system, and offer to get them the help that they need.
Okay, and Mr. Thank you very much. And I'm going to ask Mr. Munoz, so who should they talk to? If you have a friend or somebody, and maybe they don't want to talk to you, but who should they talk to? Where should they seek help?
When seeking help, sometimes we get this understanding or this confusion where only professionals can help. Professionals are great, however, they can only reach those that are nearby, and that's not everybody. Sometimes those that can help are the friends, the family members, that trusted individual that person has. Because the doctor is going to be able to help, but how does that person get to the doctor? Or how does that person get to the mental health professional? And is getting them there that plays out very importantly in the family. Because a lot of the times we see things on TV, and not things like this, where you can live with depression and you can live with a suicide intent and live a normal life. What we see on TV is the people that have depression or have suicidal thoughts are those going into places and shooting up people. That's what we get in the media. So sometimes people are scared of going to get help because they go, am I going to be crazy? Or am I going to be labeled? Am I going to be hospitalized? So when wanting to get help or wanting to seek help, you can start with friends, somebody that they trust, and then let that person move on and let them choose. Because when you're depressed, it takes over your life and you have a sense of hopelessness. You have no control over it. And giving that person an option, would you like to go? Not as, you know what, you're going to get in my car and I'm going to take you, because you're making the problem worse. And, so start with a family and then move on to a medical professional.
Okay, thank you. I'm going to raise an issue which we have found in our efforts to do some studies of depression, anxiety in the population here, and that is the stigmatization of depression and of even the concept of having any kind of behavioral health difficulty. And how do we address that at the sort of community level? Because I think, like many conditions, HIV for a long time carried, and I guess still does carry a stigma for many. But how do we deal with this, especially for these kinds of conditions? How do we approach this and I'm interested in this from a public health point of view, because the more people understand that these are not unusual things, but in fact relatively common. So anybody who wants to comment about that?
I think that what Mr. Munoz was pointing out, it is sometimes difficult for the person who's struggling with the depression or the suicidal ideations to reach for the help due to the stigma that is around this type of topics. I think that fear is not only experienced by the patient, but the family as well. And I think that a lot has to do how the family system gets impacted by the depression and having the suicidal ideas. One of the first reactions is that what is wrong here? What is going on with me? And if I go and look for this type of help, I don't think that maybe I'll get help as I'm expecting, and also maybe I'm going to get labeled. So they fear for the consequences for looking this help. So I think that we have to be more proactive as mental health providers, and if we are not being able to have all these people struggling with depression coming to us, we have to find the ways to go to them, because it's not an easy step. Even the families themselves, they feel very scared. When they come for the first time to my clinic, they're just coming and looking around and saying, well, what is going to happen here? Do we have a problem or not? So I think a lot of education has to be done. I have the fortune and I'm honored to be working with the youth population here in the Valley. And I find that the counselors in school, the social workers that are on the front lines, the teachers, they are very helpful in trying to identify these cases and trying to explain to the parents that there's help that is available for them. Still, they have their doubts and they second guess about using this type of help. So I think activities like this one, bringing awareness to the community, could help us a great deal. I just read today that President Obama has granted a fund of $235 million to educate and train people in schools to have more training in trying to identify this type of cases. So I think it's very important that we try to have closer ties with the school system to try to identify these cases. I think media as well can help us out to educate our community in identifying the treatment options that we have for this type of cases. I always explain to the patients when they come to my clinic that Even the fact that my scope of practice is prescribing medication, that doesn't mean that that's the only type of intervention that we have available. Because just taking psychiatric medications in itself, it's creating a great deal of pressure and creates a lot of a stigma on the own patient. So I explained to them that there are different steps and different options that we have available for them. So I think that one of the things that we have to do is a great deal of education.
Well, it seems to me that a venue like this, and again, I go back to think KMBH for, because I hope people will go back to, all of you will go back to your communities and say, you know, we know this is a problem in many people. It's no different from any other health issues. We all have health issues. And it's something that when we seek help, as you suggest, there's help out there. One can do things to ameliorate these problems. And so I think that's very important. I'd like to open this issue of depression up now for any questions from the audience. I would ask you to keep your questions brief and to the point so that we can accommodate as many as possible. So, and I think we have some mics here so that you can ask. So are there questions that people would like to ask about depression of any one of our panel?
Hi, I just wanted to ask what type of support groups you would recommend for someone that is suffering through depression or having suicidal ideations.
Yes, I think that resources in the community are important, and unfortunately, there are not too many resources in our communities. And I think that, starting off with awareness, but I think your point about would a support group be helpful, and I think it is. I think anytime that we share our pain, I think, a lot of what we talk about, depression and suicide, has to do with emotional pain. And so people carry them on their own. And when you share it with someone else, it relieves that burden. So I have found, especially for adolescents, I did a lot of groups when I was in the hospital, and I found that the adolescents especially benefited quite a bit from group therapy, because they seem to be able to enjoy the feedback and knowing that they're not alone, that another person their age is having similar problems and can identify with them. And so sometimes that might be one of the best approaches to treat this type of disorders like depression and suicidal thoughts. Unfortunately, there's not too many that are out there in the community. As far as I'm aware of, I don't know if there's any association in the Valley that is offering support groups for depression and for suicidal behaviors.
You have your group, the NAMI, National Alliance of Mental Illness, and that's becoming more and more active, and they do have support groups, so you could tap into that. If it is a child, I would suggest looking at your counselors at school. See what's available at school as well. If you go to church, sometimes religious organizations will have very good support groups, and then of course your mental health professionals, your private clinics like Dr. Torres, Tropical Texas for mental health and mental retardation, and then the private practitioners that are in the community. So it is an area that forums like this are very important for educating people and for and understanding that we don't have all the answers, and we definitely do not have all the resources that we need. Mental health is coming of age. More and more people are becoming aware of it, and I think that the more education, the more awareness, the more resources we will have.
And I think there's, I was referring specifically to support groups out in the community, but I think, other types of therapy, especially certain types of individual therapies, are very, very helpful for depression and for suicidal behaviors, especially what we call cognitive behavioral therapy. It's very effective. It's time limited. It focuses on restructuring the way people think. When people get depressed, there's a lot of changes that go on, not only the symptoms that we talked about, but there are mental changes that occur in the way people look at themselves, how they look at the world around them, how they look at their future. And so helping the person look at those thoughts and changing them makes a major difference in the way they feel about themselves and how they cope with depression and suicide.
Other question? Please.
I noticed that during the film, there was a young man named Giancarlo who was talking about his depression. Do you all by any chance know the statistics for depression among the LGBT community? The little boy had mentioned that he was gay and that he was going through depression. I think this is something that we need to talk about because we're hearing about bullying. We're hearing about all of these negative things that are happening to LGBT youth. And the question I have is, do you all have any statistics on that?
We know I don't have specific statistics about the rates compared to other groups, but we do know that people that are in the specific groups of gay, lesbians, and other groups tend to be more at risk. And especially for suicide, there's a lot of stigma. There's a lot of non-acceptance, especially with starting off with the family. A lot of I see adolescents that just have a fear that their parents are going to reject them, their siblings, their friends, their community, and I think that that alienates them quite a bit from others. And I think when I've seen let's say an adolescent with that is homosexual, and that they talk to their parents, and their parents are accepting of them, and say, you know, you're our child, and we accept you, and we love you. It's an incredible burden. I think once you get the parents to accept them, other people, it's going to be hard, but not the major task there. The major barrier is the family, and I think that leads to more mental health problems. It leads to alienation. It leads to drug use. It leads to a lot of problems with feeling that they're all alone, and so more risk for depression and suicide. But I don't have a specific.
I have two pieces of data that may help with this. One is that young people in that category, in any one of these categories, are 2 to 3 times more likely to try to commit suicide. And in fact, 30% of all of the suicides in this age group are by people who are gay, lesbian, transgender, that whole area. And of course, we're seeing really major changes in our society, particularly among young people, of acceptance of people who are gay or lesbian, or in this particular group, even to the point of people who are bisexual, who have, and I think we now understand from the medical side that this is simply not a moral issue. It is, and I'm editorializing a little bit, it's a biological issue. And we have to learn to accept that this is the way people are, and try to learn to accept them, not just from their family, but as their friends. Because I think when that happens, these numbers of suicides are far more likely to go down, and clearly that's very important.
Yeah. And I just want to say that at least as I talk to my patients. I feel that at least some of them feel that their peer groups are more accepting. It's becoming more acceptable. I think a lot of times it's a different generation. You know, the parents, the grandparents, the uncles, the adults have a harder time. But children look to their parents for acceptance. You want their acceptance overall, and it's not any different for this group. And so there's a lot of stress and a lot of pain that goes through that process, and it leads to a lot of people either moving away from their homes, moving into other communities, where nobody knows them, but that brings its own risks of being alone and alienated. So.
I had a question in regards to the resources. What can we do, or what can we do to improve our resources, which I know leads to quality of life issues?
Well, I think, again, one of the main things we can do is exactly what we're doing tonight, is getting the word out, educating people, advocating for the services, advocating for equity as far as, insurance for individuals that have mental illness. Just, it's an illness just like diabetes and asthma, high blood pressure. So the more we advocate for individuals with mental illness, and the more we educate our communities and our county agencies, those that have the power and the control in our community and in our country, the more we will be able to do as far as getting resources. We've seen some increase. I think, Dr. Gutierrez with Tropical Texas, over the course of the past couple of years, you've seen growth there and more services being offered in the community, trying to keep people, out of the hospital. So there is hope on the horizon, but we need to just educate and, accept it and understand it more. And I'm sure my colleagues would have some other things to say.
Let me just make a comment that I think there's some hope in regards to improving. As an agency, one of my roles is to recruit psychiatrists, and we're always having a problem recruiting psychiatrists for our clinics. One of the things that we are seeing, we're involved with the RAC, which is the Regional Academic Health Center, which is hopefully going to become a full-blown medical school, and part of that requires that there's residency programs where doctors train, and we are in the process of starting a psychiatry residency program, which will put out psychiatry residents. Hopefully they'll stay in the Valley. I wouldn't see why they wouldn't after spending years here, and I think that will allow not only psychiatrists, but I think we need more licensed professional counselors, psychologists, social workers, caseworkers, where all of this kind of approaches are not done by one person. It really is a teamwork. Psychiatric nurses, and so I think the more people get involved, there'll be more resources of this in the future.
If I can just add also, about 6 years ago, the Brownsville area, and I'm from Brownsville, I grew up in Brownsville, so it's very important to me, and being able to come home and give as far as mental health is very important. But about 6 years ago, Valley Baptist was asked to get into the behavioral health business. And so at that point in time, there was not one psychiatrist in the Brownsville area. I think there was only one private psychiatrist in Harlingen. And so we decided to go ahead, and the first thing we did was to open an inpatient behavioral health unit, and trying to establish an infrastructure, because in talking about the residency program, you have to have an infrastructure to attract psychiatrists. Since Valley Baptist opened the Valley Baptist East Campus, we have been able to attract the clinicians, the licensed clinical social workers, the licensed professional counselors, psychiatrists, psychiatric nurses. So it's building that infrastructure in our community and not having people have to go to San Antonio or Austin if they need behavioral health care.
I would also submit that the fact that we don't have very much resources across the country for behavioral health speaks volumes about the fact that it is in fact stigmatized by the government, by society in general, because it tends to get buried, and even the insurance companies are reticent to provide funding for it, and yet we're all recognizing it plays an important role. I'm going to now let's have the next question.
Gloria Casas, and I'm a school trustee. And from that perspective, I have a question, and it's for everybody, but mainly for Mr. Munoz, because I see mental health, we've been speaking about it from the medical facility part, but from the social perspective, as a school trustee, that I feel a tremendous responsibility for creating an environment that is conducive to the professionals that we have and to the children, the families that we serve. What would be the best approach to address it from a policy perspective? You really can't go and say, well, let's make a policy that everybody gets mental health, services. Would it be something like, let's make a policy that children will be taught coping skills at some point throughout their curriculum? Is that something that would be of a benefit to teach coping skills to the children? Make sure that that's very embedded in what we do every day. Because I see a person having strong coping skills, being able to deal with situations that in other situations would create depression. And I'm not a professional, I'm just a school trustee, so I'm really looking forward to whatever you tell me.
About changing policy, that'd be up to every district. But when you talk about children, the problem with children is, unlike an adult, they cannot tell you some of the feelings. It's, for example, I have 2 kids. They both cried when they were hungry, when their diaper needed to be changed, when they were cold. They didn't say, Dad, can you cover me because tengo frío, So it's learning and teaching your child how to ask for that help. And with children, they don't say, I'm depressed. They say things like, I'm bored. I don't want to go to school anymore. Little things, or they regress. A child that had been potty trained is now urinating their bed. Something's wrong there. But by allowing the child and teaching the child to become familiar with what is right and wrong and what can be mental health and what they can do to help themselves is a big step, especially in our society, because we live in a culture, in la cultura, where when sometimes things hurt, as a male, I'm not allowed to say it hurts. I have to suck it up because I have to be a man. So, and we've been doing that a lot more with our culture, teaching them it's okay to ask for help. Because when you go to mental health, there's a couple things. You're admitting that you need help, and you're admitting something's wrong. And sometimes that's hard for people, and nothing has to be wrong completely for you to ask for help. So teaching somebody at a young age that it's okay to ask for help and that the brain is just another organ would be ideal.
I also wanted to add specifically on your question. I think one of the things about school programs, as you know, as a trustee, there's always funding. That any program costs extra money, and as you know, education has not been on the priority list. So I think when you start thinking about integrating new programs, I think it's very important to really look at what programs have shown to be successful. Because, one thing we don't want to do is say, let's institute this, we think that this might help, when there's no proven data. You don't want to throw money into something that might not be helpful. We do know that there are some programs that have been tested and have been shown to be effective. I think we want some evidence-based program. And I was thinking specifically about, programs that deal with bullying in school, which can become a major problem. And I think, you can talk about that a little bit more. But I see that, across the country, there are places that are instituting programs that are really very helpful. And I think also suicide prevention programs that can be helpful to be instituted, where there's policies and procedures that the school can take when kids are at risk. And I think identifying them, we've talked today that, having this general conversations like we're having now helps people become aware and say, oh, I didn't know what depression was. I thought you had to be, a certain way. So I think just knowing, having teachers and having administrators and nurses know that when that student is having problems, instead of saying, you have a referral only, why don't you go and talk with the nurse? Maybe the nurse will ask you more specifics and say, I think you need to talk with the counselor. This is very serious. We need to make a referral. So I think there are programs that have been shown to be effective, and I think the schools can and should be looking out for those programs and invest in programs and policies that have been shown to be effective and preventive.
So with that, I think we're going to move now to the next session, because this is a perfect segue into bullying. And it's become a very prominent topic. The case I just cited, we hear about them almost every day. They often lead to suicide or to some very bad outcomes. And so I want to ask a series of questions to talk about bullying, because and clearly it's an issue in schools, a major issue. And so I want to ask Dr. Gutierrez, sort of what forms does bullying take? I mean, I don't know if you see this in your practice. I suspect
yes, quite
you
a
probably
bit. Actually, in part of we have evaluations that we do when people come in, which is a structured type of specific questions that we ask. And I've incorporated that into my evaluation. I always ask about, how they're doing in school, and how they're doing with their social relationships. I ask them, have you experienced any bullying, or have you been a perpetrator of bullying? Because sometimes people say, well, no, I bully people, and that's important too. We have to help them understand why they do it and what could they do to stop it. So yes, we need to look for it, and we need to ask questions about it now, specifically in our assessments, and specifically about what types of bullying. Well, we have the type of bullying that has always been there, and bullying has to do with a repeated verbal or physical aggression towards someone. And the important thing about bullying is that there's a power differential, okay? There's someone that is bigger, stronger than you, or that has something over you that they can make you suffer. And so there is the bullying that has always gone on in the schools. It's not something new. I think we're talking about it more, but now we have the added cyberbullying that has become pervasive now. I hear a lot of my patients, talking about it, that someone's calling them names, or is threatening them, or threatening to say something or show something on Facebook, a picture, a video. An ex-boyfriend, ex-girlfriend wants to get someone embarrassed or shamed, and so they threaten to put things on some of this social medias. And so that creates a lot of stress, a lot of concerns, because as we have always known, if it was bullying at school, you always had the hope that at the end of the day the bell would ring and you could go home and kind of at least get away from it. Nowadays with cyberbullying, this goes on. Adolescents carry their phones all the time, and so they're connected with everybody, and so they have Facebook, they have other social medias, so they can be constantly bullied around the clock. They wake up and they say, well, why do you look at this if someone is doing it? So I just want to know what they're saying about me, but then it affects me. So it's something. One of the problems with the cyberbullying is that sometimes it's very hard to get away from, and so you need to take some specific actions to deal with that. So.
I want to ask Mr. Munoz to describe to us a typical bully of today. What do you see in your experience? And I know you have a lot of experience with bullying in working with young people. What characterizes a bully today?
And some people want it to be that jock or the popular kid, but sometimes it's not that person. And a bully can come in different forms, and usually high self-esteem is there to an extent, but we look at these traits and we try to portray this monster, when we talk about, bad things, all these things appear, but we sometimes overlook the fact that the bully himself has been bullied before or has been the victim of something. And we say, okay, when we think of let's get help, let's implement a program, we want to defend the victim, but when in reality we need to defend both, because the bully himself may be coming from a dysfunctional family, a place where maybe his parents are alcoholics and are abusing him. He's coming from a culture that was taught that violence is okay. If you're allowed to hit, you're allowed to verbally be aggressive, it's okay. I think it's a time where we have to educate both. You get the person that is being bullied, and you talk to them about what they can do to avoid it. What can they do? Because sometimes we can't get rid of bullying in the way that you get the bully away and now it's gone. That doesn't happen. The bullying can continue years, decades after. You have grown individuals that are still saying, what they did to me when I was in elementary still hurts, right? And how do you do that? How do you cope with that? And, we do a lot of, we have counseling that you can do to try and avoid that. But, going back to the educators and going back to the people that are supposed to be there to protect you, what can they do? And it's, be aggressive about it. Have you noticed when you get on 77, there's a bunch of signs that say DWI will cost you so many $1,000s a year. DWI, you drive drunk, you get arrested. Why do they do that? Because they want to get a message across. And that is the same thing we can do with bullying. Get the message across that bullying will not be accepted and that there will be consequences if bullying occurs. But educate people on what bullying is. A lot of the times, people say, I didn't know I was hurting the kid. We were all laughing, everybody was having a good time, except that person. Education is the key when talking about bullying and implementing programs that will address it.
Okay. So I want to ask Dr. Torres about how do, and Dr. Gutierrez talked also about cyberbullying. So how do we get a handle on cyberbullying? I don't know if you see it in the young people that you see in your practice, but I think this is becoming. We probably see the tip of the iceberg, but I have a feeling there's a lot more going on. And what do you think should be done, and how should people deal with it in their everyday life? Because I think a lot of it happens literally every day.
Yeah, I do agree. It's something that is becoming more frequent. I see it coming up more in the consults that we do with the patients coming to the clinic. Either when there's a first suicidal attempt, it becomes pretty common to see the disclosure that something has been going on the Facebook. Pictures being posted, situations being discussed among a group of young people, singling out somebody else. And I also see it when some of my patients, they have been doing well with their medications for a period of time, and suddenly this comes up, and then we go into a crisis. I think that part of what we have to do is, I think the school system is doing a great job in trying to identify the situations. I think there's two things into it. As Mr. Munoz was saying, we tend to focus more on the victim. But we really have to understand that the bully, him or herself, has some issues that might merit some kind of intervention. And sometimes we miss that point, and maybe no interventions are done in that perspective. What I see as a challenge is the interface between the school system and the parents. I frequently see the school system playing the parent role, and it's really difficult. I have seen many situations where the parents, they have been made aware of the situation that is happening in school, and sometimes nothing is being done. The teachers themselves, they recommend to go and see a mental health professional, a counselor, or a psychiatrist, but The parents, they don't take an active role in this until something happens. I think that we need to work more on the awareness, and as you were discussing before, if the school system is trying to work on some type of program, is to work with the kids in some kind of curriculum, that could be an option, but it's super important to keep in mind that we need to educate our parents as well, because there's a great deal of denial that is happening, and I see pretty frequent. As you were saying, Mr. Munoz, maybe sometimes you just have to suck it up, in quotation marks, and you have to try to deal with the situation. But sometimes parents do not understand what it means for a young kid to be singled out on the cyberspace, on the Facebook.
And Becky Tresnicki, I'd like, first of all, there's a new word that came up that I haven't seen, but you guys probably have, called bullycide, which is new to me, and but clearly it is, as it implies, pushes young people, as we heard today, to contemplate or commit suicide. Is there a class or something that could be put into schools that, do you think, that would address, and I think education, clearly, on both sides, as you've all said, the bullies and those who are being bullied, but how do we do that in the schools, and what's out there that could help too?
I think that the schools deserve a lot of credit over the course of the last couple of years. I personally have gone in and done quite a few presentations to teachers and to counselors on bullying, and so they are wanting to be educated on it, wanting to do something about it. I agree with Dr. Gutierrez that when you're thinking about a program, look at what is a best practice, and there are best practices out there for bullying programs. And you must get your parents involved. The parents are the key to the success of any bullying program within the school district. They have to work in conjunction, like Dr. Torres said. It's a heightened awareness right now. I think the momentum again has started, and we just need to continue to advocate for these programs and use us as a resource. If you're a school board member, use us as a resource to try and help you. What is a best practice, and how can we implement that?
Thank you. I'd like to open this up now for questions from the audience. If there are questions about bullying, try to stay focused on this. We have some other ones that are going to come up in the next couple of sessions. But are there questions about bullying?
School counselor, and I see the importance of educating. And I have a suggestion. We're talking about reaching and educating the educators and the parents as well. And I think that's the major key. CPR training, you do it every 2 years. And same thing with depression and bullying. Sometimes it's hard to get the parents to attend meetings. I've done myself bullying presentations, but only a few of parents show up. So what can we do to get the majority of the parents to get them educated on these issues? I'm suggesting that perhaps during at the beginning of the year or during open house, most of the parents show up, allowed certain time for a presentation for these issues and get them. And same thing with the teachers. To have trainings on depression, have trainings on bullying on a yearly basis perhaps, because sometimes we need to be reminded and even motivated to do something about it. And we're professionals. We need to keep in mind and work as a team. And what better to get the parents and the teachers on one force, on one team, to really make a difference to help the children, because children, they're not going to speak out. I've worked as a counselor for past 8 years, and I recall very few times, and I work at elementary, and I recall one time that a kid has come to me and say, you know what, I'm thinking about doing this to me, to ending my life. So we need to reach students, and we need to be educated, and we need the help of the teachers, and we need the help of the parents.
Thank you very much for that helpful comment. Are there questions? Yeah. Right, we have a question right next door.
Yes, I am a teacher also. I'm actually a teacher. He's a counselor. And I just want to comment, based on what the panel has been saying, I think we have to teach our students and our children that it's okay to have problems, that problems is not for crazy people, that it's a universal thing, and that everyone has problems, but we cope with problems differently. And I also would like to add to what Dr. Gutierrez had said and mentioned about a client, that the mother told her child, you have everything, when I used to be your age, I used to do so many things. But, sometimes I believe that parents have been using technology as a babysitter. And maybe cyberbullying wouldn't be happening, perhaps, if parents didn't have their children be so much in the computer, online, using cell phones and electronic devices. I think that's my opinion. That's how I want to go.
We actually have a program at the School of Public Health, particularly that addresses not this, but it could, the issue of child obesity, and its purpose is to get people out from in front of the television and the computer and outside being active, and this could be a solution perhaps for a lot of things. Other questions?
A little while ago you mentioned about the support group, how friends help and how they can help you keep on going. I have seen through the years how sometimes teenagers are more prone to talking to their friends than to parents. When you talk about bullying, I'm a chaplain student, and part of my training is to knock on doors in the hospital and speak to patients. And something that I've seen at least twice, how do parents cope when the bully is a friend? Because I've seen at least twice that the person who's pushing you and wanting you to hurt yourself, it's somebody close to the patient. And it's how do parents cope with that? Because sometimes the bully doesn't seem like a bully, but as a person who's close to the patient, how can parents cope with that without pushing, your own son or your own, son or daughter? How can parents cope with that type of bullying?
Comments from anyone?
Dr. Rodriguez talked about the power differential, and sometimes we don't want to be bullied and we don't want to be hurt, but we also don't want to be lonely. And you can use that with a lot of different things. For example, relationships where one partner is being beaten. They say this is bad, but being alone is worse. And sometimes what happens is youth, really all they have to show is their persona and who do I belong with. And if I'm with him, even if he hits me or he treats me bad, not that he does, right? But if he did, at least people will accept me because I'm with him. So sometimes that power differential plays out, and even though I'm hurting, in a way I tell myself I'm gaining something. People are respecting me, and people aren't seeing that I'm being mistreated, so that's okay. And the thing about bullying is it goes undetected for so long, and people say, why? These teachers are paid to watch these kids. Usually the average bullying time is 37 seconds. That is quick. So a lot of people will not notice it. And another thing is that a lot of the places that people do the bullying is some places where you should be, you're usually in large crowds. For example, hallways, when class lets out. When you're in the restroom where a lot of the time there's no supervision. Playgrounds, when usually the ratio of students to teachers, it's high. So we need to pay attention to all these little keys. And sometimes we as parents say, it's so easy, just don't hang out with them. Who else do I hang out with? Sometimes that's what it boils down to. And we accept the oppression, not because we want to and because we like it, but more because what else do I do? And in the eyes of the child, that's the only option.
And I think that's a very important point that you're bringing out, that it's not uncommon that the bully comes from someone that recently was your friend and that no longer is your friend. They moved on, and it happens a lot with cliques of, for example, if you look at girls in the ages of 11 to 13, someone all of a sudden was in your group, and all of a sudden, for no apparent reason, they're not cool anymore, and they're out of the group. And one way of separating from that person now is to say mean things about them, to start gossiping, to create all these innuendos about them, and that creates tension, which creates then power struggles, aggression, and a lot of young girls tell me, I'm being bullied by this person who was my best friend. And I said, what happened? She thinks that I started talking to her ex-boyfriend, and now I have the wrath of all her friends when this person's only my friend. And so, yes, it's very common that the bullying starts not, and I can take it one step further. It's not uncommon to be bullied by older siblings, and a lot of my patients tell me, I feel I come home to deal with my older brother or my older sister that doesn't let go, constantly is harassing me and doing this. And parents say, well, I just think they're siblings and they're sibling rivalries. And so you really have to be very specific when the parents say, there's a power differential here. You really have to take a stand and say, this is not acceptable, and you need to do what you need to do to ensure that stops.
Okay, thank you very much. I think we'll move now to an important, sorry, is there one more question?
What's that? Yeah, I'll hold it. Okay, he's going to hold it. Okay. I had a two-part question. Question number one is, I teach bullying in my classes. I'm a school counselor, but I think the word bullying to me sounds negative in a sense that people don't really know what they mean, but they need to teach the child that under bullying it's more like you're being picked on. In the old days when I was in elementary, and it's a matter of teaching to respect each other, keep your hands to yourself, and don't use verbal words against your friends. If those things are taught at an early age and at home by the parents or addressed in some way, I think the bullying would be reduced in the elementary schools or wherever it is. But somehow it's being missed along the line. When I hear the word bullying, to me it sounds like a bad word. I think it should be more like picked on, have respect. Those issues should be addressed more than just the word bullying, because when you use the word bullying, it sounds like it doesn't feel like it's hitting the mark, And my second question was, I wanted to go back to, if you don't mind, to
do you have a question? I didn't hear a question in the first, but do you have a question?
Yes. My question was, that was my comment. Okay. Now my question is this: in early depression in the child that I saw in the film my question is, does early depression like a child starts when he's born, or is something that happens in his life and causes depression? In other words, is it inherited, or is it just something that throughout his life it might be causes? Like you mentioned, the rape, that was something that happened, but maybe before that the child was not depressed. But my question is, does early childhood depression, is it when it starts, is it inherited, or is it something that happens in early life? That's my question. Thank you.
Yeah, and I think that question hasn't been fully resolved. We do know that there are some genetic component to it, because you see in families that, and you ask about their family trees and family history, and sometimes people will say, no, there's nobody in my family. But then, you ask specifically, and they say, well, yes, my mother or my grandmother went through this, or my brother, but, he got over it. And so you do see a family history of this, and there is data showing that there's a component of depression that does it is carried in the genes. But I do think the environment also plays a part. Trauma, early childhood trauma, poor attachments. You know, I saw, and I've seen over the years a lot of children in foster care, and seeing them in good homes, which really, you know, makes a difference. But they still carry quite a bit of depression and other types of disorders because of the traumatic events, because of the losses, because of their genes, and exposure to drugs during their their formation. So there's a lot of factors that contribute to childhood depression. But you know, there's a lot of questions that that people sometimes, or a question that people sometimes say: is it possible for a child to get depressed? I mean, what they haven't really experienced much to be at that point. But someone like in my field that sees children, and it does happen, and children do get depressed and exhibit all these symptoms that we talk about, where they are they lose interest, they don't sleep, they cry all the time. The parents say, you know, I don't know how to make them feel okay. It seems like from the last few months, something has really clicked, and you're seeing all the same symptoms that you do see in adolescents and adults. So it's a combination of factors, hereditary and environmental.
We have
Good.
a question over here. One last question.
Oh, sorry, go ahead.
I think you got to a little bit of that, but I want to know if there's any information or kind of studies on the effects of bullying on health and educational attainment, both on the victim and on the bully.
71% of school shooters have been victims of bullying. That's a big percentage. Another one is that between somebody that was bullied, they were 2 to 9 times more likely to consider suicide than somebody that was not bullied. Health-wise, depression can lead to it. The sense of being hopeless, that you cannot do anything about what's happening to you, your self-esteem coming down can lead to depression and other health-related issues.
Good. All right, let's move on to now another important topic, or back to a topic that was alluded to a little bit earlier, and that is the gay, lesbian, bisexual, transgender, questioning intersexual youth. And there turns out to be a whole spectrum of these terms. And I'm going to ask Dr. Torres this question. So in this community, you've been practicing in this community, how is this kind of lifestyle perceived? Do you see them in your practice? And do you think that people in this community who are members of one of those groups are more likely to have some kind of behavioral health issue? Or even suicide?
Yes, definitely. There can be some correlation, especially in South Texas, and the majority of the population down here were Latinos, and we are less acceptant about different sexual preferences. And kind of coming out of the closet is a big and huge issue. Not infrequent, I have had to evaluate kids that they were having a really rough time trying to communicate to their parents that they were feeling different in terms of their sexual orientation. And they were having a difficult time getting this across, and maybe parents were having an expectation. Sometimes even what is sad is that the parents know that something might be going on in this regard, but they don't offer to bring it up for a discussion. Even parents, they feel afraid themselves to bring it up for discussion. And this is a situation that creates a great deal of tension. I have had the opportunity to practice psychiatry down here in South Texas, in New York State, and Massachusetts. And I think our society down here tends to be more rigid in terms of accepting these type of topics for discussion, and it makes a big difference. I have had patients that had attempted suicide because they were having a rough time trying to communicate some difficulties or some of the issues that they were having with their sexual preferences.
So, in this, I'm going to ask this to Becky Tresnicki. So, in this society, what about the peers of these people? Are they more likely to be accepting than the parents, or what's sort of the current situation with peers of people, of young people in this group?
Right. My experience has been most definitely. The peer group is more accepting. The younger people are just a lot more accepting rather than the adults when you're talking about these issues. I think it's definitely the culture plays into it, some other things as well. But they do have a peer group support there, and my primary focus right now is on inpatient psychiatric units. So unfortunately, I see the end result most of the time of everything that we're talking about. And so individuals who have attempted suicide or having suicidal ideations because of these issues will come in and they will talk about, you know, their friends are accepting, but they don't know how to tell their parents or their grandparents or this type of thing.
Well, I think this is, and I'll throw this out to anybody who wants to respond. This is a very tough subject, but is there a role for schools here? Is there a role for, from the point of view of education, is there a role, or is it too early for this kind of issue to be sort of discussed in a straightforward way in schools?
I think it is discussed all the time. I think this is not a hush-hush situation in schools. I'm not there in the schools, but at least from what I hear, you know, kids do talk about it.
No, I'm sure kids do, but is there a role for an actual class or more formal approach to education about this in the school, or is that too early to expect? Yeah, kids for sure are going to talk about it.
Yes. Well, you know, I think that there would be a role for discussion in regards to the effects that someone could have. For example, the higher risk of mental health problems, the higher risk of suicide, the feelings of alienation. I think those kind of issues, hopefully people would understand them. And if they're not, if this is something that is becoming an issue, and let's say if the student is having these problems, can he go like anyone else to the nurse, to the counselor? Can they openly talk about that? And can they have that kind of support? And can that person feel comfortable in dealing with these issues in a non-judgmental way, regardless how you feel about it, and whatever your value systems or your beliefs are, that the role is to be able to say, I'm non-judgmental about people that are coming to me for help, and I'm here to be supportive. You can feel safe and secure in talking about this. Is there a role for the school counselor or for someone in school to say, you know what, I want to be able to talk to my parents, but I don't know how to do this, and there's a lot of stress about this. Is there something that could be helpful? So the question that I think that you're asking is should there be some type of training for counselors or nurses, teachers, about this specific thing? And I think this is kind of what we're doing tonight. You know, I hope that these topics are talked about. I think that this is one of the few times that I've sat in a panel and I've talked about depression, that this was part of the agenda. So I think it's something that hopefully will start being talked about in topics that when we talk about depression, when we talk about suicide, because we talk about these things a lot, but typically we don't have a section about about this specific group. And so I think this is a good start tonight.
Yeah, I asked that question because we implied, we and people in the audience implied that we should be doing more, perhaps, with depression and bullying in schools. And here's another group that everybody is, or that many people are struggling with, and I'm just, that's the reason I asked that question. So,
may I say something?
Sure, please.
In my personal life, I have many gay friends. And it's funny when I ask, well, when did you know you were gay? They said, when did you know you were heterosexual, right? And, you know, they tell me, I've known I was gay since I was little. And so when you ask, should there be, I think there should be. Because these kids do not have people to turn to most of the time, because you're taught to be a boy or you're taught to be a girl, but you're not taught to be a boy if you're a girl, and you're not taught to be a boy, you know, vice versa. You're taught one or the other. So who do you talk to when you're saying, hey, I'm a boy, but I like boys? Who do you talk to? However, being in Texas, being very conservative, I think this topic may not appear as soon as we would want it to. It'd be kind of like trying to introduce comprehensive sex education into the classroom paid by public tax dollars. Should it happen? Yes. Do we need to do it? Yes. People need a program that can say, you know what, this is what you may expect coming out of the closet. These are the challenges that you will encounter when coming out of the closet. This is how you can talk to your parents. And understand this. This is how you can. You're not telling somebody, this is how you become gay. You're telling them, this is how you can do things if you are gay. Big difference. And sometimes people don't understand what that difference is, and they just say, no, we're not going to do it. We say, let's celebrate diversity. Diversity means difference in all angles, not the ones you choose to elect and say, okay, that's different, I like it, let's go with that. You know, diversity is complete. Anything can go.
Are there questions from the audience? I think we're going to have some questions here. Please. Let's try to keep focused at questions. If you have a comment, please try to make it brief, to the point.
We probably are aware that as early as recently as 1970, homosexuality was considered a mental disorder, as per the what is the name of the manual that
DSM.
Yes, and so yes, it's been a while since 1970, but I think that the university, it's great that this is being held here. I wish this were packed, this place right now. And I think it's very good that we have these presenters speaking. I'd like to ask you directly to each of the experts here, if you might believe that we are really taking baby steps as far as mental health is concerned. One quick example. Last month we celebrated the 10th anniversary of two horrific events. One, locally, the murder and beheading of 3 children who's the author of that claimed he was hearing voices. And secondly, going to fight the Iraq War, our president said that he spoke with God, and God instructed him to do that. In hindsight, most people think it was a bad idea. When a psychiatrist or a doctor of mental health has a person telling him that he hears voices or speaks to, whether it be imagined, real, a deity, are we doing everything we can to try to change the course of mental health by being condescending, or should we question everybody, even our presidents, when they say such a thing?
I'm not sure. I'm not sure what the question is specifically. But specifically,
I'm not sure I understood the question either.
The question was.
Just very briefly, I'd like to know policy at the highest level. Are we truly? The president of the governing school board team is an ultra-conservatist who challenges creation, and this is the person that's in charge of the education system. Thank you for that. Challenges evolution, and that was just in last month's local media, statewide media, national media. And what I'm saying is that it seems like some of the top positions in the country and state are being governed and dictated by people who may not have the mindset that allows progressive advancement in medical areas, in science, mental illness.
We'll take that as a comment, and could we have a next question?
Hi, I want to thank the panel. My question is, almost in every issue we've talked about, I've had it, and I grew up being bullied. I grew up in South Texas, moved away, lived in different areas of the country, come back to Texas, and like when they say the world's going to end, everybody's going to move to Texas, because we're 40 years behind the rest of the country. Now, as I find myself as an adult being 46, sometimes I find myself being the bully. At what point, how do I approach that? How do I go, because I see commercials and stuff saying, stop the bullying, but what do I do? Maybe this is a thing I'm going to add to my next session, Dr. Torres, is how do I go back to the person I just realized I bullied? I didn't want to do it, but all of a sudden I had to get my point across, and oh my God, I just became a bully. What do I do at that point? How do I make myself realize that? How do I approach that? That's my question.
Well, one of the things that I explain to the patients that they come to the clinic is that when they come to see me, the medication is one of the treatment options, but the medication is worth taking it as long as you work on reframing the way that you think about certain situations in your life. In a way, on a lot of the research that has been done in psychology, we learn our behaviors up to a certain age, and from that point on, what we keep doing is we are repeating certain patterns. And as those patterns repeat themselves, are more difficult to change them. And now neuroscience has been showing the same thing. The certain circuitry in the neurons get stronger, or they get enhanced as a behavior is repeating itself. Is a medication going to change your behaviors? I don't think so. It can help, but what we really need to work on is in psychotherapy, which is the type of intervention that I recommend most of the time. Now, according to the person's style, there might be different type of psychotherapies that can be used, because we have to do an inventory on what are the motivations for a person to have certain type of behaviors. And we have to understand what are the goals or what are the gains that the patient is obtaining by doing these type of behaviors. It's not infrequent to hear the situation that you're describing, where you might have been bullied at one time and now you turn to be the bully. Because in a way, in a certain part of the psyche, that conflict hasn't been gone and it hasn't been resolved. So in an attempt to resolve that conflict, you're trying to reenact that situation to see if you can gain some mastery on that situation so you can let it go. So in this case, I think that one of the things that would be very powerful would be to work in psychotherapy, to understand your own motivations on why this situation is happening and repeating itself.
Are there questions about the specific topic now about sexual orientation and the health consequences?
I just wanted to say that as a high school counselor, I do see a lot of students coming in about the gay and lesbian, and the things that you talked about is that it is more accepted now because they are open about it and telling all their friends and things like that, especially with girls, and they show affection in public. And but one of the things, a lot of students come in and tell me that they think that they're having feelings that they are bisexual. So and they don't know whether to tell their parents or not, or how to tell their parents. And if they're very young, like ninth graders, what I say to them is that, well, right now, everyone may be having those type of thoughts. You're changing and you're growing every day and your hormones are growing. And it's, it may be normal for you to be having thoughts. Now, if you're acting on them, then that's a different thing. That's about all I could say to them. Now, on the other spectrum, some come and tell me that they are gay. and their parents don't accept it. And I've had parents come in crying and wanting me to counsel their kids because they don't want them to be gay. So, I mean, those are the issues that we deal with in the school. But lately, I have been having a whole bunch of students come in to tell me that they think that they're bisexual. And I mean, the only thing I could think of telling them is just give it time and see before you tell your parents. And they start telling all their friends, and I'm telling them, you're already telling everybody. If that is what you want, then that is fine. Or if they need help telling the parents, I can help them tell their parents.
Thank you very much.
No question, just
There's
comments.
one last question. I think I saw one last hand. Yes.
Do we have a higher than average suicide rate among LGBT children and adolescents because of the conservative culture that we have here? Or when we mention this, are the numbers not different depending on where we are in the United States?
I don't think we have statistics. We were just
Yeah, we were talking about this earlier, and we don't have any local data. It doesn't mean that they don't exist. I just haven't looked for them, and I don't know if anybody else has. Well, I just commented earlier that clearly there's a much higher probability of trying to commit suicide, and 30% of all suicides of this age group are people in one of these categories. And so I think the question is, in our specific community, we don't have any data.
Well, I don't think that we have any data in the local community, but there has been some research that has been done by the New York Psychiatric Institute with Columbia University. And Dr. Brent has been working on certain things, not this topic in specific, but what they have pointed out is that any kind of unique characteristic that a person might have, that means that this person can be singled out and be subject to peer pressure or cultural pressure, that constitutes a risk factor for suicide. So that has been demonstrated, yes.
You know, in this topic, we mentioned younger people being more accepting, and you mentioned people are more likely to tell their friends. A lot of the individuals that I've spoken to privately and then, you know, in my short practice, telling their friends is okay, but they want their family to know. You know, when I got accepted to the university, I could care less if my friends knew. I wanted my family to know, because being Hispanic, we're taught that familismo. We're taught that your family is your everything. And when they don't know, and they don't know that special part of you that you want them to know, it's hard. So it may be easy to tell your friend, but in reality, some of these individuals want to tell their family because that's who really, really matters to them. So we're at a good step, but we need to go further. And you know, there's a great organization, PFLAG, that works with the parents of children that are gay, lesbian, bisexual, transgendered, questioning. You know, they work with them. You know, how do you involve your parent? Because for a parent, your child is gay. What do I do now? How do I help him? How do I not? Because your home is your shelter at times. And if I'm not being sheltering, if I'm not taking care of my child needs, who will?
I just need to, you know, also make a comment that it's not as easy to deal with these things. They're complex. You know, if you look at, as I said, and I look at the parent, because they're both sitting in my room, and I'm seeing the angst of the child or the adolescent wanting to have acceptance from their parents. I'm also seeing the angst, concerns, disappointment, fear, a lot of feelings on the parent side that they also have to be able to go through, because a lot of times parents see it as a loss. I feel like, so things are not going to be the way I expected them. I had plans for you for the rest of your life, and now you're different. I mean, it might not be that, but from the parents' perspective, they are going through an adjustment period too. And I think it's very important to be sensitive to the adolescent or that is coming out or trying to get this information to their parents and get that acceptance, but also to be able to have the appropriate counseling for the parents and letting them know that most of these things aren't resolved in one conversation. that this is a process that will take maybe years, and there will be different facets or different stages where you thought that you had all this resolved, and all of a sudden there's a new issue to this. So this is a work in progress from both sides.
So I would dare say there's also probably some level of guilt in many parents thinking that they had something. This was back when I was growing up in pediatrics, the autism at that time was considered to be something that parents did for kids when they were developing, and they had an overprotective mother, all sorts of things that were put forth for autistic kids, but they all went back to sort of generating guilt in the parents, and I think probably this also plays some role in. And I think this is where, again, education, research on these issues is so important that we really understand the basis of them. And they're biological. And so the more we understand about this, the clearer it becomes, and I think people can get rid of their guilt and start to then cope with the differences. So I want to move now to an important subject that also has become more prominent, and that is sexual abuse of young people and its impact. And Becky Tresnicki, I want to ask you this question. How important is the issue of sexual abuse in children in our community, and does it contribute to depression and suicide? And we'll start with you. There may be other comments from others.
I think definitely that my colleagues, Dr. Gutierrez and Dr. Torres, are a lot more qualified, but what I can say is that in my years of experience, I think that there's a definite correlation, and just because of the trauma, anytime you are traumatized, and you are going to have some kind of a reaction. So the individuals that I have seen are definitely having a negative effect, and it definitely impacts not only their immediate life and not only themselves, but their entire families. And so it becomes a family issue and not just an individual issue.
I think it's also important to keep in consideration that trauma, especially at an early age, will dictate on how you're going to relate to others throughout your whole life. And it is very sad, because I think one of the topics that has a great deal of guilt and shame is sexual abuse, because the victim will tend to think that he or she was the one responsible for the situation. And the earlier the age is of the trauma, it's going to impact more on how you build up on your attachments. A lot on how we determine our own behaviors throughout life is on how well we can establish those attachments in our early life. So there's going to be a great deal of anxiety, a great deal of depression. Sometimes those attachments will become very chaotic, and I think that in the psychodynamic perspective, it's very important how people who have been victim of sexual abuse or any kind of trauma in the early life, they learn to cope with crisis. It's very difficult. It's very easy for them to go into emotional chaos when there's a crisis. And this is the type of situations where we're going to see a lot of the self-harming, because sometimes cutting my wrist or cutting my arms can relieve a lot of tension, because these people live in fear, in a great deal of anxiety and a chronic depression. And because of the same guilt and the shame that these situations might cause on a person, it's going to be much more difficult to come across and ask for help. And the only times that we are going to be able to notice that there's a crisis going on is when they self-inflict injuries.
So I want to move to another important issue, and all these issues are important. All of them contribute to, as we saw in the film, to depression, thoughts or acts of suicide in our young people. And so we unfortunately, even in 2 hours, we don't have time to cover everything. But I want to ask Dr. Gutierrez, so alcohol and drug abuse in young people, is it the result of something else, or is it the cause of or is it some of both?
Well, as you know, drugs and alcohol use is pretty pervasive in our society. Some legal and some illegal. We're a gateway we're a corridor here for transport of drugs through the country. A lot of them stay here and get spread out to the general population. So there's quite a bit of drugs, not only here, but all over the country. And so one is availability. Okay, I always ask about substance abuse. Does the father, the mother, the older siblings use drugs? I think that they're at very high risk if someone in the family is already doing that. Because the drugs probably are already there in the home. So there's available drugs. It's kind of normalized because if my dad or my mom uses them, then what is wrong with me using them? So having exposure to that from earlier on, and you would be surprised that sometimes the medical students will ask me, why would you ask a 9-year-old if they use drugs? Because they do. A lot of the 8, 9-year-olds are already using drugs. It's there in their house and they have access to them. And so, as a child psychiatrist, I also treat a lot of children with ADHD. And one of the things that we know about ADHD is that a third of people that have attention deficit hyperactive disorder will develop a substance abuse problem. So that's a lot if you compare it with the general population. So just having that risk factor, I start talking with my patients that have ADHD. When they start getting into this 8, 9-year-old, I start telling them, these are risk factors that you want to be aware of, and it's better if you never start because then you have to deal with it as an ongoing problem. So to answer the question, I think there's a variety. We do know that alcoholism, for example, if you have a male father that was an alcoholic, the chances of their children having is very high, even in adopted out children. So even if you were adopted into a family that doesn't drink, if your biological father drank, you have a big chance of becoming an alcoholic, even when you were not exposed to it, because there's some genetic component for this addiction. But again, the environment, the exposure, the availability, the people you hang out with, all those things have a big influence on using drugs and alcohol.
And it certainly is a growing,
very pervasive problem, especially with mental health. If you look at people that have mental health issues, we call this comorbidities. It's not enough to have one disorder. People that have one disorder are higher risk of having one or more disorders. So substance abuse is a very common comorbid disorder for depression, anxiety, ADHD, and other sexually abused patients. So sometimes it's a way of coping, of dealing with anxiety, of self-medicating, but easily becomes an addicting factor and becomes a problem in itself.
So I hear you saying it goes both ways.
Yes, it
if
does.
a child, a 9-year-old, starts using drugs because their family, then it can lead to all sorts of problems,
Yes.
Behavioral health problems.
Yes.
Or somebody who's been abused in some other way or had some trauma may do this as a coping mechanism.
And one point that I wanted to just add to this is that, we've been talking about suicide and about dangerous behaviors. It's very common to have someone that has been depressed, that has had suicidal thoughts, that has never really crossed that barrier to hurt themselves. They thought about it, but all of a sudden they go out to a party, they smoke some pot, they drink alcohol, and all of a sudden they get those feelings come out very strongly. Remember that alcohol and some of these drugs are very strong disinhibitors. Here in the valley, there's a wide use of what we call benzodiazepines and Rohypnol pills that are bought very easily for $1 or $2 a pill, and kids take them to get high or deal with situations going on. But these drugs are very strong disinhibitors. So if you're an aggressive person, you're more likely to become more aggressive during that episode. If you are depressed and suicidal, there's the likelihood that you could hurt yourself more, because what it does, it disinhibits you. So that's I just want to put that in regards to this issues of drug abuse and alcohol use.
What we've seen, and we're going to go ahead and wrap up here. We've seen that we've talked about suicide, but we've seen that depression, endogenous depression, or depression because of some other issue, bullying, sexual orientation, sexual abuse, alcohol and drug abuse, and other things. There are stresses and other issues that lead to suicide or thoughts of suicide or efforts of suicide. So we as a society need to understand and start to be able to discuss these issues at every level, and to bring them out in the open, and particularly be able to talk with those victims of all of these afflictions, if we want to be able to change things. I want to invite each of the panelists to sort of summarize their thoughts about this issue just briefly, and then I think we'll wrap up. So we'll start with Dr. Torres.
I just want to say and to communicate to the community that although we have limited resources, we do have some steps and some treatment options available, and we can use them, and there's nothing wrong with it. I think that one of the final messages that I might want to convey is what I see in the parents is they take a long time to seek for these type of services, and what happens is that the only time that they try to search for something, for some help, is in the middle of a crisis. So what do we have available outside for our kids when they're in the middle of an emergency? Our physicians in the emergency rooms in the different hospitals, Valley Regional, Valley Baptist, the hospitals in McAllen, they have trained physicians to deal with this kind of situations. We have social workers that are available 24/7 through these services that they can do crisis intervention. Tropical Texas has a crisis team that they can send professionals to assess situation and to try to do intervention in crisis. As the psychiatrists, we do have clinics. Sometimes parents think that they just can call and they can go in. Sometimes they end up having a great deal of frustration because they cannot access the service right away. But we have also psychiatric units available. Valley Baptist is in the project of building up an adolescent unit coming soon. We have child and adolescent units in McAllen and Edinburgh, Doctors Hospital, South Texas Behavioral. We have Dr. Gutierrez, and we're fortunate to have Dr. Gutierrez here in the Valley providing child psychiatric services. We have different type of counselors. There are social workers that they train to become counselors. We have licensed professional counselors, ALPCs. We also have psychologists in the community. And all these are professionals. It's not only a doctor. We have a good range of different mental health providers that can offer any type of intervention in the middle of a crisis. So don't feel afraid. We are there for you. We are there to help you. And you're not alone on this.
Thank you. Mr. Munoz?
Suicide can be something that is hard to understand. Get informed on the topic. See what you can do. And be patient with the individual that you're going to be talking to if you think they're suicidal, because suicide is not the problem. Suicide is their solution to a perceived problem, and sometimes the people that need the most love are the hardest to love. However, they need your love. They need you to be there because they have lost hope. They have lost a reason to live. But you can help them through that, and not only professionals can help, anybody can, and if you want to, you can too.
Thank you.
Well, first, I would just like to thank you for asking me to be part of the panel. It's been my pleasure to speak with such qualified individuals and to talk to you. I think that this is the very first step that we need to do, and it needs to spread, and that's to talk about things, to educate things. I'd like to say ditto to everything that Dr. Torres so eloquently said, and just to let you know, I've been doing behavioral health for more years than I care to think about, and wouldn't want to do anything else. It's very, very special. It's a very needed service, and just remember that there's always help and there's always hope. You never give up, because we're never going to give up on you. So we are here. We are your resource in the Brownsville, Harlingen area, so please know that you can call on us.
Well, I also want to thank you all for taking some time off from your busy schedules to be here tonight. We've been here for quite a while and appreciate your patience. I hope that some of these comments, some of these thoughts that we shared with you could be helpful, that I think that, we have limited resources, but I think the more people become interested, you, I'm sure, will hopefully talk with your colleagues, with your friends. They will know more. And I think one of the things that we know about what we talked about today is that when people get depressed, when they get suicidal, they feel like they're alone. They feel that nobody understands them. They feel that they're a burden on society, and they feel that they're alienated. And what helps is a connection, human connection. When you can connect with people and show them that you do care, that as the film showed today, that you can be connected even for a little bit, and you might feel like, how much can I do? But all of us can do something. When someone approaches you and you listen to them, it's a help, and hopefully that everything that was discussed here, hopefully that you will be able to take that home with you, and it could be of some help. And I won't repeat the resources. I only that for all of you to know that we do have this crisis service through Tropical Texas. It's a 24/7. There's a crisis hotline. We have hundreds and hundreds of calls that happen every month, and about 50% of these are activated to a mobile crisis team that can go to the different settings, and we have to respond within an hour. So even people that are not going to be in service, they will have access to that crisis team if needed, and have ability to deal, at least to get through that crisis. So hopefully that would be something that would be helpful to the community.